Dear friends, we have some technical problems. Sometimes YouTube has problems also. Excuse me for the technical issues and give us 2-3 minutes and we will back to the My name is Roin Rekwawa, and on behalf of Silk Road Heart Rate Society, I am honored to invite you to Innovations in Heart Failure Treatment Conference that will take place this Friday and Saturday on December 25th and 26th, 2020. Together with these prominent speakers, we bring another conference to your mobile and desktop devices. Join us for this 2 days journey through latest findings and research on heart failure treatment. Register on our website to get access to this conference. I will see you this Friday, December 25th at 4 p.m. Nur-Sultan time. Dear friends, esteemed colleagues, ladies and gentlemen, good morning, good afternoon, and good evening to everyone joining our conference from different countries and different time zones. I am happy and honored to host today's conference live from Almaty, Kazakhstan. And on behalf of Silk Road Heart Rate Society, allow to me welcome you here. I hope you will find today's discussion and speakers inspiring and useful. In 2017, a small group of doctors united around the single idea to train, educate, and bring together cardiologists and cardiac electrophysiologists. As a result of this effort, Silk Road Heart Rhythm Society was created. The main focus of Silk Road Heart Rhythm Society is on teaching, collaboration, and sharing experience. For first time, we have prepared all lecture in the two languages, English language and Russian language. Before every presentation starts, we will share a link for Russian version right here in the chat of the conference. Pay attention to the chat and click to link if you want to watch the presentation in Russian language. Уважаемые коллеги, мы подготовили все доклады на английском и на русском языках. Перед началом каждого доклада мы опубликуем ссылку на русскую версию доклада в чате конференции. Следите за нашим чатом и проходите по ссылке, чтобы послушать лекцию на русском языке. После окончания лекции вы сможете вернуться обратно в нашу студию, пройдя по ссылке на самом видео. So let me introduce my friend, co-chair Emin Evrenosjan from the Associated Professor of Cardiology from Dokuz Eylül University, Turkey. Please, Emin, join us.
Thanks for this warm welcome, Rowan. It's always a great pleasure to be a part of the Silk Road Society, and also I'm very glad that the COVID did not stop these organizations because it's a very nice networking based on teaching the cardiologists, especially on the electrophysiology field and on arrhythmias. And today, I think you are organizing a very nice, good prepared program combining the arrhythmias and the heart failure, because the cardiology, the fields of the cardiology is emerging very fast in this era, and we cannot follow everything in other fields of the cardiology. So I think it's a very nice program. Because of the sake of time, I think it's better to start the program. But first, I would like to also emphasize the difficulties, technical difficulties to create a bilingual program. So I think it's also worth to say and congratulate the technical support. Thank you very much.
So in the first lecture, first topic is yours. Do implantable cardioverter defibrillator still reduce mortality in heart failure? Emin Evrenosjan from Turkey, please.
Hello, dear friends. Nice to meet again. Unfortunately, we are far away and online, and I'm really missing the Silk Road meetings. It was not only an academic meeting, it was also very good opportunity for improving our friendship and networking. So my topic is do ICDs still reduce mortality in heart failure? It's very important question because there is rising concerns about this area. The answer is in this figure, actually. Most of the patients remain stable during 3 years. However, we lost 15% of them due to progression of the pump failure, and we lose them due to heart failure progression. And unfortunately, 15% of them die suddenly due to arrhythmic events. And ICDs, as all we know, are the most efficient technology for detecting and treating this kind of arrhythmic deaths, as you all see here. Do we have the data? Yeah, everything with the ICD started with the secondary prevention trials, with cash and SITS trials, and ICDs show benefit on amiodarone for both all-cause mortality and especially on arrhythmic deaths. And we checked the subgroup. The ICDs was very efficient in patients who had reduced ejection fraction less than 35%. These patients are the secondary prevention patients belonging this studies has very high risk for sudden cardiac death. But if they presents a very small group, but the patient who has heart failure in general population, maybe they have less incidence, but 2-3 times more events are belong to this heart failure population group. So the secondary, after the secondary prevention trials, primary prevention trials investigated, and for both ischemic and non-ischemic patient groups, ICDs show benefit on all-cause mortality and arrhythmic deaths. Since that time, although we have some concerns about the non-ischemic groups, the ICDs became a cornerstone treatment for sudden cardiac death prevention. And then the guidelines directed treat ICD indications was using two parameters. The functional capacity and ejection fraction for both ischemic and non-ischemic patients. So for many years we were implanting ICDs by heart by using only these two criteria. And as I told you, we had some concerns about the non-ischemic patients, but these questions became more obvious with the recent Danish trial. It's not so new now, but it changed a lot of thinking in this area. So it was a very big trial, more than 1,000 non-ischemic cardiomyopathy patients who has heart failure, symptomatic heart failure, conducted in the study and followed up more than 5 years. And what we have seen in this trial, the ICDs did not reduce the all-cause mortality and cardiovascular deaths. So obviously it was reducing this sudden cardiac death because it was preventing the arrhythmic events. But the non-significance on all-cause mortality increased the concerns about the ICD therapies in these non-ischemic patient groups. Instead of saying ICDs doesn't help these patients, we have to take some lessons from the Danish trial. First of all, it shows the importance of the optimal medical treatment in heart failure patients. Sudden cardiac heart failure, that heart failure study is one of the first studies. 70% of the people were using beta blockers, and very few of them were taking aldosterone antagonists. However, in Danish trial, almost all patients were using beta blockers, and more than half of the patients were using aldosterone antagonists. So by time, a lot of things changed with the therapies on heart failure. I like this graph a lot. It shows the timeline and the change in pharmacotherapy. So in this graph, you can see the sudden cardiac death risk by year. And in the here on the left side, you can see the first heart failure studies, ACE inhibitor and beta blocker therapies. And you can see how the annual sudden death risk is decreased by time. And you can see at the end, in 2011, you can see the risk with the current therapy, including aldosterone antagonist and ARNIs. So it's very important to use optimal medical therapy. And it is also a good graph, shows the stepwise decrease of the annual sudden death by using different type of pharmacotherapy. So the ACE inhibitors decrease, and also beta blockers decrease annual sudden death, similarly to the ACE inhibitor, a little bit more than beta blockers. Aldosterone antagonists also add some benefits. After these cornerstone medical treatments, ICDs, of course, add some benefit, but fewer than the pharmacotherapy. So, with this optimal medical treatment, you can see how the baseline risk of sudden cardiac death is decreasing. You can see the first trials, first primary prevention trials, and the Danish trial. So by time, the risk is decreasing, and the risk of total mortality is decreasing. So it's getting harder to show the benefit of the ICDs, because ICDs has few space to show the benefit. And also the numbers need to treat is increasing by time because of the difficulties that I told you. The second important lesson is the benefit of the CRTs in these non-ischemic cardiomyopathy patients. In this trial, 58% of the patients received CRTs, and all we know the CRTs has great benefit on mortality in selected patients without ICDs alone. So this is important to use CRTs in patients with non-ischemic cardiomyopathy and indicated by the guidelines. The third importance, and I think the most important thing is the patient selection. If you check the Danish trial, there are two groups who has the most benefit. One of them is the younger age. The young patient has significant benefit with the ICDs because the cumulative risk increased by year. So they have more life to live, so they have more risk to have. The other risk is the group is the patient who has less heart failure symptoms and less heart failure biomarkers. So that if the patient has mild heart failure, at least less symptomatic, they have more risk. Their risk of sudden cardiac death is more than the risk of dying with the pump failure. This graph explains what I'm telling and simplifies it. So if we check the risk of that and the relation with the ejection fraction, the red line shows us the all-cause mortality, and the green line shows us the sudden death. Both increases by the reduced ejection fraction. But if we check the risk of death, all-cause mortality, to patient A, who has ejection fraction 30%, the risk of sudden death and all-cause mortality is not that much different. But the patient B, who has a 15% ejection fraction, Of course, sudden cardiac death risk is increasing, but the dying because of the other reason, non-sudden death, because of the other reasons like comorbidities and the pump failure, advanced heart failure, it's getting much more than the sudden death. So the proportional risk of sudden death is less. So the question is, predict the sudden cardiac death or the ICD benefit. So we have two questions. At what level of the proportional sudden cardiac risk is an ICD likely to be benefit, or we have to also discover the all mortality risk if the sudden cardiac death is so low that ICD doesn't make benefit. For this, we have some heart failure risk models to realize, to decide the patient's overall risk, and which I recommend to use a Seattle heart failure model. You can use it by using this internet site, as I mentioned, that I mentioned below. So if this is the screen of this calculator, Seattle heart failure model calculator. So I put on some data here. The patient age is 65, male patient, symptomatic, and the ejection fraction is 30. By adding some treatments, as you can see, because look at the change by the intervention. In this case, the optimal medical treatment, I put ACE inhibitors, aldosterone blocker, and beta blocker. And if you check, this is the baseline. The 5-year mortality is 60%. And by adding these treatments, it's come into 30%. You can check the survival curve in the right upper corner. And if we add ICDs on the optimal medical treatment, it also gives us some benefit. So we can use to realize the survival expectancies and also the effects of the comorbidities. To summary, so the patient with heart failure goes to advanced heart failure, all we know it. But they have two ways: to go to the sudden cardiac death or dying from some other reasons. So the risk for sudden cardiac risk, like fibrosis, autonomic dysfunctions, and genetics, can show us who will have the most benefit from ICDs, because the patients who doesn't have, who has increased risk for non-sudden risks like comorbidities or age, they will not have benefit from the ICDs. To realize the risk of the sudden death, we are actually have a lot of techniques and a lot of parameters to assess. We have clinical factors, ECGs, echo, MRI, genetic testing, and also many parameters related with these techniques to understand who has the sudden cardiac risk or the risk related with the pump failure. However, we only use the functional capacity and the ejection fraction to decide the indication for the ICDs. So we need better tools to risk assessment. One of them looks like imaging techniques like MRI. So the presence of the scars seems very effective to detect sudden cardiac death risk. This is a very nice study. meta-analysis of the 29 trials. And if we check here, presence of the scar, late gadolinium enhancements is highly related with sudden arrhythmic events. And furthermore, which is very interesting, it's also true for the patients for the ejection fraction more than 35%. So for 35, less than 35, we already implant the ICDs. But the one who we don't implant the ICDs, presence scar seems very important to realize and detect patients who are under the risk. And if we check the patients who had ICD implantation for primary prevention, presence of the scar shows huge difference between the one who doesn't have scar. So the scar seems a real risk factor. There's another study on the CRT patients, and patients who implanted CRTs had MRI initially, and we checked sudden cardiac death risk. The patients with the fibrosis has more events, arrhythmic events. So you can see with the ICDs, these are the CRTD patients, CRTP patients. In the patients who has fibrosis in the ventricles, the CRTs has significant benefit over CRTPs. And also, if the patient doesn't have fibrosis, mid-wall fibrosis, the CRT ICDs doesn't put additional benefit on CRTP. So the main problem in the DCMs, non-ischemic patients, is the risk stratification. And the reason, in my opinion, is the difference in the etiology. So if we call them the non-ischemic patients or DCMs, it's a basket, we put everything in it. So there are some genetic disorders which will not improve, will go worse by time, but some toxic related, like alcohol-related or peripartum related DCMs will sometimes improve by time, and the risk of sudden cardiac death will improve, or some of them stay stable by time. So I think one of the more important thing is the etiology. And sometimes genetics might help us. It's a big trial, so 1,400 patients with a genetic analysis over 10 years experience. And the patient who doesn't have mutation has better survival curve. They live longer, but patient has mutation, they have worse outcome. And even the type of the mutation affect the survival. So in addition to having mutation, phospholamban mutations or lamin A mutations has worse survival than the one who has other mutations. That's why nowadays we implant ICDs in different cutoff ejection fraction values. In the patients who have phospholamban or lamin A mutations, the cutoff for ejection fraction is less than 35% because these are progressive diseases. So how we can predict the sudden cardiac death better? The new risk stratifications parameters beyond ejection fraction and heart failure functional capacity is really needed. Disease-specific risk factors and thresholds should be determined by time. Updating the validity of the risk factors with each new heart failure treatment is crucial, as I told you in the beginning of my slides. So if we have a treatment, the efficacy of the treatment should be tested by the new pharmatherapies. And how can we increase the benefit of the ICDs? We have to choose the patients who will get the most benefit with the ICDs. ICDs are not very innocent treatments, the lifelong treatments. So we need patient-tailored risk assessment. We need better differential diagnosis based on etiology, especially in non-ischemic patients. We need to understand the pathogenesis, and we need better heart failure treatment. I would like to thank all the community and for your patience. Hope to meet in good places, face to face. Looking forward for that.
Dr. Özcan, thank you very much for your interesting presentation. Let me remind that you can ask questions via the YouTube chat to Dr. Özcan or all our team, and you can join once more the conference. And let me announce in Russian language that, уважаемые коллеги, мы подготовили доклады на русском и на английском языках. Соответственно, вы можете получить, мы опубликуем ссылку на русскую версию доклада в чате конференции. Соответственно, вы всегда получите перед каждого доклада специальную ссылку, на которую вы можете перейти и послушать лекцию на русском языке. Пожалуйста, пользуйтесь этим. Please, Emin Evren, we need. I think we don't have it. Yeah.
I would like to present our next speaker, Amina Rokisheva. She is the head of the Cardiology and Rehabilitation Department at Scientific Research Institute of Cardiology and Internal Diseases. She has also a PhD degree, and in addition to clinical practice, she is a board member of European Heart Failure Association. Her topic is SGLT2 inhibitors, fourth cornerstone of heart failure treatment. Amina, please. Okay, it's a pleasure.
Thank you very much for introduction. I'm very pleased to welcome you and to be part of your conference. I will also agree that it's very pity that we can't meet personally and we can't organize a conference offsite, but we have to use all possibilities to continue our work, for fruitful collaboration and for fruitful work. So my talk is dedicated to SGLT2 inhibitors, and I think it's a prominent, and I think it's one of our future treatments in heart failure. So I would like to start my presentation.
Please.
Good evening, ladies and gentlemen. I'm really grateful to be part of this event because, of course, it's very important to meet personally. Unfortunately, due to pandemic situation, we can't do that right now, and we have to take this opportunity to meet with each other, to take time for discussion. And my talk will be dedicated to SGLT2 and their treatment in heart failure. First, I would like to start my talk with a legendary talk of Professor
So
John
I'm now
McMurray.
going to move to the primary outcome. So if you remember, this was a composite of cardiovascular death, heart failure hospitalization, or emergent heart failure visits. This is what we saw in the placebo group. So despite these patients having mainly mild to moderately severe symptoms, despite excellent conventional therapy, 25% of them had a major heart failure event within just 24 months of follow-up. This is the dapagliflozin group, and so you can see that the Kaplan-Meier curve started to separate early and continued to separate during the duration of the trial. There was a 26% relative risk reduction in the primary composite outcome. That was a highly statistically significant benefit. And as you can see, the number needed to treat over the median follow-up of 18.2 months was only 21.
So why are the SGLT2 inhibitors legendary? Let's try to discuss that among this talk. And I would like to start my talk exactly with two meta-analyses that were presented and that were published in 2007. Both of them showed that, unfortunately, non-insulin antihyperglycemic therapy are not safe according to adverse event for cardiovascular system. And the following year, FDA made a guidance that sponsors have to be very accurate and they have to be responsible for cardiovascular outcomes for MACE. These events should include cardiovascular mortality, myocardial infarction, and stroke. So we are talking about three important MACE, and of course, they also can add other 2 or 3 MACE more. That can be hospitalization for acute coronary syndrome, urgent revascularization procedures, and possibly other endpoints. Since that time, the number of cardiovascular outcome trials remarkably increased. And we can see here on this slide that the trials are exactly trials for SGLT2 inhibitors such as EMPA-REG, such as the CANVAS trial, VERTIS trial, and DECLARE-TIMI trial were part of these cardiovascular outcome trials. The first and the initial indication for SGLT2 inhibitors were exactly glycemic control for patients with type 2 diabetes. We can see that the main action of SGLT2 inhibitors is to inhibit proteins in a proximal tubule that possibly are responsible for 90% for glucose reabsorption. So we understand that their glucose will not be reabsorbed up to 40 to 120 milligram per deciliter. 4 pivotal trials showed their significant impact for patients, not only for type 2 diabetes, but also for cardiovascular patients. There were EMPA-REG outcome trial with empagliflozin, CANVAS trial with canagliflozin, where DECLARE-TIMI trial with dapagliflozin, and VERTIS trial with erdagliflozin. These trials showed the following. EMPA-REG and CANVAS program showed significant reduction for MACE. We can see here in a green line, and non-significant reduction for DECLARE-TIMI and VERTIS trials. For cardiovascular deaths, we can see the moderate overall among all these trials, except one. EMPA-REG outcome trial showed substantial reduction for cardiovascular death. And of course, we can see that heart failure hospitalization were significantly lower among all these trials. So probably the action of SGLT2 not only for type 2 diabetes, but additionally, we can, as we saw, that reduce heart failure hospitalization They reduced MACE, and of course, they reduced cardiovascular death. Trial that was presented by Professor John McMurray during EC Congress 2019 was DAPA-HF trial. Dapagliflozin in patients with heart failure and reduced ejection fraction with and without diabetes. That was the first trial presented for not for type 2 diabetes patients, but for heart failure patients. This trial showed, as we remember, this trial showed significant reduction, relative risk reduction, 26%. The number needed to treat was very low, 21. As we can see for cardiovascular primary and secondary endpoints, favorable effect of dapagliflozin compared to placebo among all these endpoints. Another trial which was presented this year during EC Congress 2020 was EMPEROR-Reduced trial. And again, we are talking about heart failure patients with and without diabetes. The number that were included into this trial was very high, 3,730 patients that were randomly assigned for two groups, empagliflozin group and placebo group. Primary outcome, we also can see that it was substantial reduction of primary outcome, 25%, because the number of adverse events in placebo group was higher than empagliflozin group. So next, there was a publication that then analyzed both these heart failure trials, DAPA-HF trial and EMPEROR-Reduced trial. This trial showed that there was no difference of the impact of SGLT2 inhibitors for patients with diabetes and without diabetes. There also was no difference of favorable effect of SGLT2 inhibitors despite ARNI. So patients who received ARNI and who were not receiving ARNI also had a favorable effect of SGLT2 inhibitors compared to placebo. So let's just try to discuss, is it only inhibition of SGLT2 proteins? Another action of SGLT2 inhibitors is to constrict afferent arteriole that later help us to decrease the intraglomerular pressure. So we can see diuresis, natriuresis, glucosuria, and of course, we also can see that it will be less proteinuria in patients who received SGLT2 inhibitors. Another action of SGLT2 inhibitors is to impact for left ventricle wall stress. So they reduce the impact for a left ventricle wall. It means that they reduce preload, but also they increase myocardial energetics, and it is a metabolic effect of SGLT2 inhibitors. So they are reducing afterload. It means that probably the SGLT2 inhibitors has not only glycemic control, but also metabolodiuretic mechanism of action. But also we can see that it was not only for patients with heart failure, with type 2 diabetes, but secondary endpoints and secondary sub-analysis showed for renal-related composite outcomes showed a good action, a good benefit for patients who received SGLT2 inhibitors in EMPEROR trial, CANVAS program, DECLARE-TINI, and not so significant result were in VERTUS trial. So metabolodiuretic effect was exactly in their action, which probably were in a mechanism to make this trial, DAPA-CKD trial. The trial that include only patients with chronic kidney disease. And these patients were with eGFR between 25 and 75 milliliters per minute. These patients were randomly assigned for two groups, dapagliflozin group who received 10 milligrams per day and placebo group. The main endpoints for this trial were renal function reduction or renal death, heart failure hospitalization or cardiovascular deaths, and overall mortality. And what we can see, according to at the end of this trial, so we can see that patients who received dapagliflozin trial, of course, they were they had a benefit compared to placebo among all these endpoints. Now, SGLT2 inhibitors not only for glycemic control, they also, as we talked earlier, they also had a reduction in heart failure hospitalization, in cardiovascular deaths, and MACE. But also, FDA approved another labels for chronic kidney disease or heart failure. For chronic kidney disease, canagliflozin was approved for patients, and for heart failure, dapagliflozin was approved by FDA. In 2020, there was a very interesting publication that showed that compared two different strategies for heart failure treatment. The first strategy we know very well. It's AC inhibitors or ARB plus beta blockers. And comprehensive therapy consists of RNA, beta blockers, MRI, and SGLT2 inhibitors. What we can see that this comprehensive therapy reduced for 62% primary endpoint, which was combined endpoint of cardiovascular deaths and heart failure hospitalization. Cardiovascular deaths, 50% reduction. Heart failure hospitalization alone, 68% reduction of comprehensive therapy compared to our traditional therapy. And all-cause mortality were for 47% reduction. We see the 47% reduction for comprehensive therapy. What that means? That means that if patients, let's just think, that patient in a 55-year-old with chronic heart failure with reduced ejection fraction will achieve 8 additional years free from cardiovascular death or heart failure hospitalization. But also, this patient will achieve 6 additional years of overall survival. Is it important for patients for heart failure? Of course. And I think that it's very interesting to see and to understand what will be presented during ESC Congress 2021 in heart failure guidelines. And I think that we should wait for these guidelines, and probably there will be substantial changes in these guidelines as well. Thank you.
Thank you very much, Dr. Rakisheva. Thank you very much. So, and we have another very interesting presentation from our colleague from Mongolia, Mungunulzi Khurelbatar, will present his bundle pacing in heart failure. Please, Mungun.
Hello, everyone, and thank you for the Silk Road Heart Rhythm Society for this interesting congress, and I hope everyone who is joining us is enjoying today as much as I do, and good luck.
Thank you. Please, we can start presentation.
Good day to everyone joining us today at the Innovations in Heart Failure Treatment Congress organized by the Silk Road Heart Rhythm Society and its cooperating institutions. I'm Dr. Mungulzi. I'm from the 3rd State Central Hospital of Mongolia. I would like to thank the organizers for this opportunity to share this interesting subject, His bundle pacing in treatment of heart failure. So before we start, this is the arrhythmia management team of the 3rd State Central Hospital in Mongolia. We are the first and only operating team at this point in the country, and we are very glad to be represented at this important event. So normally, heart has a conduction system that has many advantages for the heart functioning and proper pumping of the blood. Thanks to this effective conduction system, atrial ventricles, they are performing synchronous contractions. So in order to better understand his pacing, we can discuss a bit about his pacing compared to RV pacing. In this image, we see the gentlemen who have developed the pacemaker therapy in 1950s. Right ventricular pacing has been effective treatment of significant bradycardia since its development until today. However, today we know RV, right ventricular pacing, is causing non-physiological cell-to-cell activation. And this activation pattern is developing ventricular dysynchrony, or the electrical change that causes worsening or development of depletion in heart mechanical function. This was demonstrated by David Trial that right ventricular pacing increased the risk of death and hospitalization for new or worsened heart failure. Studies have also demonstrated higher the pacing percentage, actually the worse the outcome is. For example, in these graphs, we can see comparison between below 40, above 40%, below 80 and above 80% pacing rates. The graph shows higher the pacing percentage, their significant decrease in the event-free survival. So researchers are in search for alternative pacing sites to mimic the physiological activation. And there are many sites are being studied. Amongst them, his bundle pacing is demonstrating to be remarkably promising. There is indeed growing number of interest toward his pacing technique, and that can be seen from the rapidly growing number of publications in the last few years. This is one fascinating study comparing his bundle pacing to right ventricular pacing. From the table, we can see participants in two groups, his bundle pacing and right ventricular pacing, were the same in terms of age, disease, pacing modes, and pacing burden. As for the implantation procedures, the procedure time and fluoroscopy time were longer in his bundle pacing. But we can see that QRS duration shortened more in his bundle pacing group. However, pacing threshold was higher in his bundle pacing. During the follow-up, the change in threshold, however, was not significantly different, as you can see in this table. For study results, primary outcome, including death, heart failure hospitalization, and upgrade to biventricular pacing, was significantly lower in his bundle pacing group. As for the secondary outcomes, all-cause mortality and heart failure hospitalization were also lower in his bundle pacing group compared to the right ventricular pacing group. And these results are more pronounced when pacing percentage is high. On the left table, when the ventricular, on the right table, when the ventricular pacing is below 20%, actually there is no significant difference, while ventricular pacing is more than 20%, as shown in the left table graph. There start to have a significant difference in, for example, hospitalization due to heart failure. The study concluded his bundle pacing procedure is actually safe and feasible with more than 90% success rate. the procedure time, fluoroscopy time, pacing threshold was higher compared to right ventricular pacing, and there was no difference in procedural characteristics for both experienced and new operators after initial 10 procedures. This recently published meta-analysis comparing the pacing in patients with advanced AV conduction arrhythmia who have either normal or mildly reduced heart function. The major studies in this meta-analysis did demonstrate all-cause mortality is lower in his bundle or biventricular pacing compared to right ventricular pacing group. However, the researchers are still discussing few challenges with his bundle pacing. This includes high threshold, leading to faster battery depletion, requiring frequent generator changes, and or needing lead exchange and related complications to that. Also, the implant success rate is still under discussion. So we discuss about this more in depth. His bundle pacing tends to have higher threshold compared to RV pacing. And it is well demonstrated by Zanon and the team. An increased threshold may lead to need for frequent generator exchange and complications related to the surgical procedures as mentioned. And approximately 6% re-intervention rate due to late rising threshold was reported, and the lead dislodgement, macro lead dislodgement seemed to be rare. It was demonstrated also that improved tools can assist the implanter using dedicated C315 his bundle sheath actually resulted in both decreased re-interventions and as well threshold. But there are still limited tools available in the market to reach his bundle. Implanter experience is also important when doing his bundle pacing. Following increased number of cases, his capture threshold was reduced as shown in this graph. Researchers are explaining when operators are more confident and experienced, they are actually more confident to implant the lead correctly. And also, whenever there is high threshold and threshold is not appropriate, the implanter becomes more confident to re-implant to better location. The fluoroscopy time also reduced following the implantation number. Thus, the proper training and experience is important. From this study, after 40 cases of experience, actually success rate is coming to steady level. In terms of complications, the lead revision is higher during his bundle pacing. However, on the other hand, the perforation and tamponade related to larger leads seem to be lower during his bundle pacing. And in terms of the activation synchrony, actually different sites for pacing was analyzed for synchrony and activation. And this is the activation mapping from different pacing sites of the ventricle. During normal activation, we can see there is a rapidly and synchronously completed conduction within the ventricle. And when you use different sites for pacing the LV, when you are using different sites of pacing, the left ventricular apical pacing seems to create more synchronous activation within the left ventricle, but there is still dissynchrony between the ventricles. And LV activation during the RV apex and RV septum are compared to his pacing in this graph. There was a significant delay during both right ventricular apical and right ventricular septal pacing. However, during his bundle pacing, LV activation time not different compared to normal activation baseline. So actually his bundle pacing can create very physiological activation of the left ventricle. So can we use his pacing, or how is it compared to biventricular pacing during normal, during heart failure condition? The device therapy during heart failure is aimed to correct electrical impairment and possibly to improve the cardiac function further related to the impairment of the electrical activation. As we know, ventricular dysynchrony is often during the heart failure, and as we know, ventricular dysynchrony is deleterious. That is why methods of resynchrony is being studied. And one of the major studied method is biventricular pacing. And it has proven to improve the clinical outcomes when it's used. There are numerous evidences of beneficial effect of biventricular pacing. However, there are several challenges related to this methodology. It's not always possible to locate the perfect pacing site due to coronary sinus anatomy, for example. Also, biventricular pacing does not recover full physiological synchrony, because actually it was found that it is still cell-to-cell activation just from different sites, paced from the different sites. That's why when paced during narrow QRS, actually there is an increase in activation duration, meaning that there is still somewhat dysynchrony and following mechanical dysynchrony. So then his bundle pacing. His bundle pacing actually allows conduction system to be stimulated directly, resulting in normal physiological ventricular activation. This study comparing biventricular pacing against his bundle pacing. The study analyzed acute LV functional change and included patients with typical left bundle branch block and LV impairment, or typical patient for resynchronization therapy. During his bundle pacing, QRS narrowing was much greater in his bundle pacing group, as shown by the red cone, compared to the biventricular pacing expressed by the blue cone here. Also, the left ventricular activation time was reduced markedly during his bundle pacing compared to the biventricular pacing. Above mentioned changes translated into significantly improved acute hemodynamic changes during his pacing. We can presume cardiac resynchronization therapy through his bundle pacing may deliver more effective improvement in the clinical endpoints. This is the meta-analysis reviewing literature related to permanent his bundle pacing. And the meta-analysis demonstrated ejection fraction had significant improvements during his bundle pacing. And this was especially demonstrated when patients had ejection fraction of below 50% at baseline. There are many observational and cohort studies confirming the benefits of his bundle pacing in terms of QRS narrowing, in terms of baseline ejection fraction improvements. Yet we may still need to have well-powered clinical trials to conclude and to bring his bundle pacing to golden standard of treatment. And also, there are observations. Not all patients actually with bundle branch block appear to be corrected with his bundle pacing, and different success rates in demonstrated from different publications and different researchers. Still, the 2018 guideline favored his bundle pacing. Now it is 2A evidence to perform his bundle pacing for patients with ejection fraction of 36 to 50% if the pacing burden expected to be above 40%. And same guideline also recommends his bundle pacing to be considered for atrioventricular blocks at AV nodal level to maintain the physiological ventricular pacing. So still the 2018 guideline favored his bundle pacing, and now it is in 2A evidence to perform his pacing for patients with ejection fraction of 36 to 50% if the pacing burden expected to be 40%. Same guideline also recommended his bundle pacing to be considered if the AV block at AV nodal level to maintain the physiological ventricular pacing. So in conclusion, his bundle pacing proven to be feasible and safe option. It does improve the outcomes when used for bradycardia treatment. And actually it is also shown to have significant potential for the treatment of heart failure. So how about in Mongolia? We initiated his bundle pacing in 2020, so it's relatively new. It was performed by the arrhythmia management team that I have shown you, and it's located at Thursday Central Hospital. This is the National Reference Center for Cardiovascular Disease. And using this opportunity, actually, I would like to thank the Silk Road Heart Rhythm Society, the President Roendrik Fava, for his committed support for us. Due to COVID-19 pandemic, we were not able to have in-person supports during our initiation of the service. However, thanks to the modern telecommunication possibilities and committed support from the Dr. Roin, we were able to perform his bundle pacing procedures under supervision of teleconsultations. So thank you very much and enjoy the rest of the Congress. Thank you.
Mongonulzi, thank you very much for your interesting presentation. So, Emin Evren, maybe you want to comment something about heart failure patient and his bundle pacing, or like in this field something?
Yeah, it's his bundle or the left bundle pacing, more physiological pacing has a bright future. However, the heart failure patients not always have a good conduction and interventricular conduction properties, which limits the efficacy of his bundle pacing. Another issue is that the patients with the heart failure also need some ICD backup, and also it seems the appropriate ICD electrodes we cannot see in the near future that makes CRT devices using for his bundle pacing, which makes programming a little bit difficult. But I think that we are in the beginning of the very important era for the physiological pacing. I think it's a very important topic.
Yes, it was a very interesting comment. Thank you. Please, we can
okay.
go on.
And our next presenter is Amina Rakisheva again, and she will talk about another interesting topic, comorbid conditions and the heart atrial fibrillation. Amina, please.
My dear friends, dear colleagues, I'm very grateful to present and to talk about one of important disorders, atrial fibrillation. It's very important also not because of itself, but also because atrial fibrillation is always, we can see with comorbid conditions. So let's try to talk about atrial fibrillation and comorbid conditions and the management of these two disorders. And before, I would like to start with that worldwide atrial fibrillation is the most common cardiac arrhythmias, which associated with morbidity and mortality. We also shouldn't forget about burden of atrial fibrillation for public health. Their prevalence, the current prevalence of atrial fibrillation is between 2 and 4%. If we are talking about the numbers, we are talking about 43.6 million people who are suffered from atrial fibrillation. We know that people that cardiovascular disorders has non-modifiable and modifiable risk factors. For non-modifiable risk factors, we're talking about aging, genetics, sex, and ethnicity. We shouldn't forget about comorbidities. Heart failure, hypertension, diabetes, chronic kidney disease, COPD, obstructive sleep apnea. Why? Because these comorbidities also has their own impact to prognosis in atrial fibrillation patients. Let's precisely talk about aging, about heart failure, diabetes, and chronic kidney disease. Why is it so important to talk about these risk factors? Why do we need to remember of impact of comorbidities? Why should we evaluate all risk factors? Because we should remember that deaths related with atrial fibrillation, mechanism of death is exactly heart failure and comorbidities and stroke. At the same time, stroke, 20 to 30% of all strokes, of all ischemic strokes, are related to atrial fibrillation. And the mechanism is cardioembolic or related to comorbid vascular atheroma. If we are talking about left ventricular dysfunction or heart failure, we are talking that 20 to 30% of atrial fibrillation patients has dysfunction. And we are talking about excessive ventricular rate. We're talking about irregular ventricular contraction, a primary underlying cause of atrial fibrillation. That's very important not to forget about these things. A very interesting study was published in European Journal of Heart Failure that showed that in 2016, the prevalence of atrial fibrillation was about 8 million people. If we are talking about 65 and over, we can see the same tendency for people over 80 and for 65. The number is increasing, but the number will increase. If we are talking about stable increasing, it will increase up to 40 million people among all European Union countries in 2060. And we see the same tendency for the patients with age 80 and over. The same results were shown in 2015 when they just saw their prevalence of atrial fibrillation among all countries worldwide, less prevalent at the age below 40, and the prevalence was increased at the age over 80 years old. It doesn't matter what is the country. The same tendency was among all countries worldwide. Heilig and his co-authors in JAMA in 2001 showed the same results. Less patients with atrial fibrillation below 55 years old with rapid increase at the age of 80 and over. So we're talking that age is independent risk for atrial fibrillation. But at the same time, atrial fibrillation by itself is an independent risk factor for stroke, 6.5% at the age below 55 years old. And this number was increased, five-fold time increased at the age over 80, up to 30% of people with atrial fibrillation has stroke. It's very important to remember. Another study that was published and that was made in Sweden, this study included 408 patients at the age over 75 years old who were admitted for emergency reasons to hospital. Half of these patients had atrial fibrillation. Half of these patients, 71 patients, had contraindications for anticoagulant therapy. What authors have revealed after 12 months of follow-up, they revealed that ischemic stroke among patients who were not able to take anticoagulant therapy was higher. The same results, higher was risk of bleeding among patients who were not able to take anticoagulant therapy. Of course, we're talking that the ratio of ischemic stroke to bleeding was also higher among patients who were not able to take anticoagulant therapy. So we're talking that anticoagulant therapy prevents stroke, prevent even bleeding, and the ratio of stroke to bleeding. All right, so we understand that the prevention with anticoagulant therapy is very important. But what are other causes of death among anticoagulated atrial fibrillation patients? According to these results, half of these patients, the causes of half of these patients were related to cardiac causes, so heart problems. And it's very interesting to see that exactly due to prevention with anticoagulant therapy showed a very low percentage, about 6% for bleeding and 6% for ischemic stroke. So we're talking about cardiac disorders. And what are these cardiac disorders that has their own impact to mortality of atrial fibrillation patients? We're talking about sudden cardiac death. We're talking about myocardial infarction, and we're talking about heart failure. And I would like to talk about heart failure. What is the interaction? What is the relationship between atrial fibrillation and heart failure? What is important to know about this combination? Is it very important to know who was egg or chicken first? I think we should just discuss from both sides, from atrial fibrillation side and from heart failure side. From atrial fibrillation side, I would like to present to you the data from European Atrial Fibrillation Registry pilot study that showed that every second patient with atrial fibrillation has heart failure. But this prevalence was increased among hospitalized atrial fibrillation patients up to 63%. Study that include patients, COMET study, there were patients with heart failure, and sub-analysis of this study showed that patients with atrial fibrillation, with chronic atrial fibrillation, together with heart failure, has a very high death rate. But when this analysis was adjusted for age, the number of deaths was non-significant. But they also showed that the new onset of atrial fibrillation among heart failure patients significantly increases the number of deaths over 5 years of follow-up. The same results were shown from heart failure side. So heart failure registry showed that new onset of atrial fibrillation among patients with heart failure has adverse effect compared to patients who previously had atrial fibrillation. That's a very important fact. Let's try to see to this problem from anticoagulant trials side. ROCKET-HF trial also showed that for cardiovascular deaths, very important risk factors are vascular disease, heart failure, and diabetes. We also can say that heart failure was the risk factor for sudden death. All right, ROCKET-HF trial showed this result. What about RELY study? RELY study showed the same results. So heart failure, creatinine clearance less than 45 milliliters per minute, diabetes, and ejection fraction below 40 also are independent risk factors for overall cardiovascular death in RELY study. And if we can see for a Russian registry that include 1,000 patients with heart failure, they revealed that 1 of 10 patients with combination of atrial fibrillation and heart failure diagnosed with chronic kidney disease. 3 of 10 patients, again, with atrial fibrillation and heart failure had type 2 diabetes. 4 of 10 patients had previously MI. 7 of 10 patients previously had coronary artery disease. And 8 of 10 patients with atrial fibrillation and heart failure have high or very high risk, stroke risk. So we understand that this relationship has their own impact from atrial fibrillation to heart failure and vice versa. And moreover, these two disorders has lots of comorbidities and risk factors. I like this study very much because this study, one of the interesting, not only estimated their impact of atrial fibrillation and heart failure, but also estimated the modifiable risk factor of 2 disorders. This study included 34,000 women over 45 years without any cardiovascular disorders, any cardiovascular disease, without cancer. And during the long follow-up period, they revealed that the new onset of atrial fibrillation and added new onset of heart failure increased all-cause mortality. This interaction also increased cardiovascular mortality and myocardial infarction. But also, it's very interesting that they revealed that 62% of heart failure events had the same risk factors. We are talking about diabetes, we're talking about smoking, about obesity, and about hypertension. So, is it very important still to know who was egg or chicken first? I think we should, for my opinion, we should remember that atrial fibrillation and heart failure, the relationship is bidirectional. And the prevention of one disorder is preventing the other disorder. For primary prevention, we are talking about smoking, obesity, diabetes, hypertension, left ventricular hypertrophy, chronic kidney disease, sedentary lifestyle, and excess alcohol consumption. If we are talking about a secondary prevention, we are talking about prevention of stroke and thromboembolism, dementia, myocardial infarction, and death. So, once again, we should remember, if we are preventing atrial fibrillation, we are preventing heart failure. Several times we mentioned about diabetes, but not only diabetes, but also prediabetes is very important among patients with atrial fibrillation. So injurious effect of hyperglycemia has microvascular complications and microvascular complications. If we are talking about microvascular complications, we are talking about coronary artery disease, we are talking about peripheral artery disease and stroke. And if we're talking about microvascular complications, so we are talking about diabetic nephropathy, neuropathy, and retinopathy. We also should remember that diabetes patients have a higher risk of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke than patients without diabetes. And also we should remember that the risk of all-cause mortalities will be higher among patients with diabetes than without diabetes. Another very interesting study, results from REACH study. This registry was among patients with atherosclerosis, and the numbers, the sub-analysis of 4 years cardiovascular outcomes show that patients with diabetes had significantly higher rate of cardiovascular deaths, myocardial infarction or stroke, non-significant non-fatal stroke, non-fatal myocardial infarction, significantly statistically cardiovascular death and all-cause mortality compared to patients without diabetes. We also should remember about their risk scores, stroke risk scores. CHATS score has diabetes. We all remember that. Among the trials with anticoagulant therapy, the number of patients in rocket atrial fibrillation study was 40% with diabetes. Our apixaban study, Aristotle, had 25% of patients with diabetes. Engage study had 36% of patients with diabetes. And the Bigatron study had 23% of patients with diabetes. We understand that there are a huge number of patients with diabetes among these studies. And we just have to understand that the sub-analysis showed that these patients were, the average age of these patients was the same among these trials. But the main difference among these trials was a difference in CHATS score. The highest CHATS score was in rocket atrial fibrillation study. It was 3.7. But all of this study showed the same result, that use of anticoagulant therapy protect patients with atrial fibrillation and diabetes. If we are talking about cardiovascular deaths, about stroke, about major bleeding, and about ischemic heart disease. So we should remember that the use of anticoagulant therapy will prevent our patients with atrial fibrillation and diabetes also. But at the same time, we should remember that diabetes is the underlying cause, is the leading cause of renal failure, and we can see it here, that's the most prevalent cause of renal failure. And that's very important because we understand that, and we remember, we talked about that previously, that chronic kidney disease also very important modifiable risk factor for patients with atrial fibrillation. We should prevent diabetes and not to lead to renal failure. So we will prevent we will improve the prognosis for patients with atrial fibrillation. In conclusion, I would like to tell you that prevention of stroke and cardiovascular deaths is critical for non-valvular atrial fibrillation aged patients with diabetes and heart failure. I would also like to remind you that phase 3 of rocket atrial fibrillation study included 40% of non-valvular atrial fibrillation and diabetes patients with a mean CHATS score 3.7. And it showed the beneficial effect of rivaroxaban compared to warfarin. I would also like to remind you that rivaroxaban in non-valvular atrial fibrillation and diabetes patients has a real impact, a real improvement in prognosis in a real clinical world practice. So with this slide, I would like to finish my talk, and I would like to wish you a happy new year and a very good upcoming 2021 year. Let's see each other on the following year. Thank you very much for your attention.
Thank you very much for your presentation, very interesting presentation. So maybe you have some comments about heart failure treatment, new onsets, or etc. Please.
First of all, I would like once again to thank you to this possibility to be part of your very nice conference. And I would like to tell you that heart failure, unfortunately, is that the prevalence of heart failure is increasing. And we should always remember that. We should always remember that the treatment is always developing. And I think it's crucial to know every time the modern techniques and modern management of heart failure. That's why I would like to invite you to EC Congress 2021. That would be for now, it's online congress, but who knows? We hope that it will be partially online and offsite, and to see new EC guidelines on heart failure management. And secondary, I would like to wish you a happy new year, and I would like to wish you a great new year. And let's us meet 2021 as the same as we met 2020. So have a good time. Thank you very much.
Merry Christmas. Thank you very much.
I also would like to thank the organization for this nice conference, and hope we will able to meet in person in following year.
Thank you.
Roy, would you like to add something?
Maybe you comment about tomorrow.
Oh yeah, tomorrow. Maybe today we have some technical problems, but again, it's not easy to organize bilingual conferences. So I'm sure we will have very nice presentations tomorrow, mainly on heart failure topics. So please do not miss this opportunity.
Thank you. So tomorrow we will continue maybe some more interesting presentations. Our colleague from United States, Dale Yu, will joining us from the and Aliotto, Professor Aliotto he's very famous professor from Turkey. Farid Aliyev from Azerbaijan will explain us about ventricular tachycardia ablation in patients with heart failure. I will join also this conference with CRT implantation in patients with heart failure, etc. Please feel free and join our conference tomorrow. Let me announce something in Russian language. Коллеги, проверьте, пожалуйста, ваши имейлы. Мы будем новую ссылку высылать на ваши имейлы, и вы можете зайти уже новой ссылкой, через новую ссылку на завтрашнюю конференцию. Напоминаю, что завтра конференция начнется в 12 часов по времени Нур-Султана. Пожалуйста, посмотрите в ваших странах, во сколько это, и мы с удовольствием подключимся вместе с вами, будем обсуждать разные моменты сердечной недостаточности. So, and we have one interesting announcement that we have prepared quite unusual lecture for you on Instagram marketing for doctor. Tarlan Husseinov, our friend, he's the expert of this field. He will explain us about marketing and the Instagram marketing for doctors. So thank you once more very much for joining us today. Excuse us for the technical problems, but it's internet, it's YouTube, it's live, and see you tomorrow on 12 p.m. Nur-Sultan time in this studio, and we will have good conference tomorrow. I hope so. Thank you very much and bye.